Welcome to The PA is In, the show created by PAs for PAs, where codependency with your supervising physician is a thing of the past, optimal team practice is the future, and physician associate has taken the place of physician assistant as the professional title of choice. I'm Tracy Bingaman, and I'm obsessed with redefining what success as a PA looks like and what it feels like. Here you'll find the mindset shifts, systems, and processes I use to escape healthcare burnout and integrate my work into my life. Work-life balance is a myth, and an integrated life where you thrive professionally, not a balancing act, is the goal here. My mission is to help you to grow into a unicorn PA who loves their job, has abundant energy, time to spare, and work-optional financial freedom. The PA is in. Welcome back to another episode of The PA is In. Today, our guest is someone who in his clinical practice was sick and tired of sitting across the table from patients who had tried one after another antidepressant and still not seen an improvement in their symptoms. So he went about the business of building a practice that helps those patients with depression, anxiety, mood disorders in a way that has increased their resolution of symptoms by 10-fold. I'm so excited to introduce and share with you my conversation with Dr. Mikal Bailey. He is the CEO and owner of Stillwater Health. He's going to talk about his journey from employee to entrepreneur and how we can destigmatize our own mental health alongside helping our patients to get the resources that they so desperately need to address theirs. Without further ado, here he is, Dr. Mikal Bailey. Dr. Bailey, welcome to the show. Thank you so much for being here.
Good morning, Tracy. Thanks so much.
If you could just take a moment to introduce yourself to our listeners, tell us who you are and a little bit about what you do.
Yeah, well, I appreciate the opportunity, and thanks for everyone tuning in this morning. My name is Mikal Bailey. I've been a PA for a little over 20 years and had kind of a muddled background going into that in the first place. Started out as clinical laboratory sciences, thinking I wanted to do something in a lab forever, and then did reproductive medicine, which was kind of an offshoot of that, helped start a reproductive program. And when I did that, I started doing some medical illustration, and I thought, oh gosh, I like drawing. And so did some of that. So for months, I drew a bunch of reproductive organs and everything. My wife looked at that on the dining room table, and I thought, no, I don't think I want to do this forever. And started teaching, and as I did, I lectured for PA program some where I was, and ended up having an opportunity to become a PA. So did that as a career choice and stuck with it, and spent majority of my career in neurosciences. And so been anything from doing neurosurgery to neurohospitalist, orthospine, physical medicine and rehab, but always done that in an employed position. And so a couple of years ago, had opportunity to be involved in more private practice and liked the business side of things. Surprisingly, didn't think I would be interested in that. And so through kind of a series of events, made the decision to open our own practice a couple of years ago. And it's just blown up since then. So that's where we are today, working on Stillwater Health.
And tell us about Stillwater Health. What kind of patients do you take care of, and what do you do?
So we're an outpatient treatment facility, is I guess how I would describe it, meaning people can come to us. You don't have to have a referral. We certainly have our referral base, but we're an outpatient mental health treatment facility. And we can talk about this more if we want to, but for personal reasons, really, opened this because I got tired of sitting across from patients, especially in neurosciences, that were dealing with comorbid depression, anxiety, trauma, the whole gambit of mental health needs. And it's so intertwined into what they feel physically. And we could talk about that too, on just the areas of the brain that are affected and how that manifests physically. And it's a huge area of neurosciences that's growing and expanding, and we just still know so little on that. And I got tired of sitting across from these patients who had a laundry list of pills they'd been on, and sitting there thinking, hey, you want me to prescribe you one more pill, knowing statistically that I'm likely to to blow it for you. I'm really not going to get you what you need and what you're looking for. And knowing that there were some other treatment options out there that aren't sort of the mainstays, that weren't, if you crack open a textbook, you don't start reading immediately about the things that we do here at Stillwater, which we do IV ketamine, which is a psychedelic, it's referred to, or as a dissociative anesthetic. We do Spravato, which is S-ketamine. It's an L isomer of that, but that's the only prescription form of it. And then we do transcranial magnetic stimulation, or TMS. And each one of these therapies has much better statistics on making you feel better, and much better statistics on making you feel better quicker, which, if you've ever been depressed or ever had anxiety, or if you've ever tried Lexapro or Zoloft or any of these meds that we tend to peddle, you know that they don't work quickly. I mean, what did we learn in school? Hey, I'm going to give you this prescription and let's wait 6 weeks at best. And then let's say it's I don't know, kind of a mediocre response, or you're depressed and let me give you something that might make you gain 20, 30 pounds, or now you can't have any sex drive. So hope you're not depressed anymore. Hope you feel great. And so I got tired of sitting across from patients like that thinking, man, I'm just not cutting it for you. And so decided in our area where we first opened this clinic to do some market research and just see what was out there. And we don't live in a very big metro area for this first clinic. And you can search some insurance data. And I found within 5 miles of where I was thinking about putting a clinic, just a 5-mile radius, in the 12 months prior, there were almost 16,000 patients who had sought care at their primary care provider. And I looked at one ICD-10 code. I looked at just major depressive disorder, F33.2. I just looked at that and I said, let's raise the bar high. Let's look at how many of those patients have been on at least 4 different antidepressants in the last 12 months. And it was almost 16,000 people within 5 miles of this clinic. And that's honestly a gross underestimation, because that doesn't count how many people have tried 3, 2, or 1,
Or are
antidepressants,
walking
or
around with
none.
undiagnosed depression who are just
Exactly. I
suffering.
mean,
Yeah.
totally. And you're standing in the grocery store aisle with them, or pumping gas at the gas station. I mean, you look around, so many people are facing this. And it certainly got worse during COVID. And so I just kind of got to this point where I was like, I'm kind of tired of not having all the resources I want. So I decided to bring that to the community here. And it's just been phenomenal ever since then. It's been a lot of fun because patients are actually getting better and they do it pretty quickly.
Yeah. Yeah. So to the clinician listening, I'm certain that you have patients that are depressed. So I am pretty much as far removed from primary care in clinical practice as you can get. I do outpatient aesthetics, right? Like I am not. However, a surprising amount of my visits include a long treatment time where I'm treating someone and we're just shooting the shit. And as we're doing that, there's a little bit of therapy that I'm certainly underqualified to be performing happening. And I have realized that this is something that affects so many people, so many patients, people that you know. What I want to know is, how do you get over this stigma or over this kind of barrier that probably both patients and providers have about these non-traditional treatments? So this is not what we were taught to think of first line when we have a patient who's depressed, right? We're not thinking, I wonder if we should give them IV ketamine. Like that is not top of mind. So how have you guys navigated that as a practice in terms of for patients and for referring providers?
That's an excellent question. Where do you even begin to answer that question? I guess you can go sort of a cliche way first, and let's start with just COVID, what COVID did to society. If you looked at early in COVID, there was a study in a journal, Brain Behavior and Immunity, and it was looking interestingly enough, they were kind of focusing on how does mood and depression just affect your immune response and some of your behaviors. And they specifically looked at healthcare workers facing the COVID crisis. And I think it's like, I don't know, 33,000 patients, something like that, or providers. And out of those healthcare workers, over about roughly a quarter of them, and this was early in COVID, mind you, were struggling with major depressive disorder. Roughly a quarter of them were, or actually, no, it wasn't even more than that. It was like 30 some percent was dealing with insomnia. And so they knew early on that just the social dynamics that were changing with COVID and the stressors were impacting healthcare workers. And so that's just healthcare workers. If you look at stats nationwide, though, like just you mentioned, just the people that you're sitting talking to while you're doing aesthetics, the prevalence of depression or mood, we'll just say mood abnormalities that become more persistent, is just massive nationwide. It varies a little bit regionally, but pretty consistently across the board, our nation has really suffered. And part of that is the infrastructure for where you seek help for that is relatively, I won't say it's non-existent, but it's pretty archaic, really, in terms of what the needs are. It's one of the areas that we're starting to hear more about it, I think, since COVID. And I hate to focus too much on COVID because it was certainly pre-existent. But the normalization of how to think about your mental health still has a long way to come. And part of my impetus of opening Stillwater was to eventually get this to a point where, Tracy, if you have strep throat, you might go to urgent care or go see your PA and say, hey, my throat hurts. And they say, hey, take this antibiotic. And you say, great, because that makes sense. But for some reason, we still, as a society, say, if you're feeling low today, you should keep it to yourself. If you're stressed out and let's say you have a bad marriage at home, keep that secret. Don't tell anybody about it because that's embarrassing. And if your job isn't going so well and you're trying your best, but your boss is a jerk, or, day in and day out, this routine of I got to get up, I got to get the kids ready, I got to go work hard, so I got to pay bills, and I got to keep doing it because if I don't, then I can't pay my bills, or I've got all this stuff. I mean, there's just what it is just on the periphery. There's so many things, and the way I explain it to patients, if you and I are talking here, and I'm dealing with depression, you and I might be talking, but my brain sees it like this: like I've got this bill to pay, and then I've got I didn't sleep well last night, and this conversation with so and so didn't go well, and oh gosh, I forgot to do that, and that idiot pulled out in front of me, and pretty soon you're peering through all this junk all the time, and your brain is tired. And for some reason, still in this culture, we think we should just not talk about it. We shouldn't deal with it, and we don't teach people how to deal with it. And we don't learn as providers very well how to teach people how to do it. Because in primary care, like you said, you're far removed from primary care. Primary care is supposed to be front line. How much education do any of us get really to help patients navigate that? So I want to normalize how people think about it and not feel like, I guess, pride may be a burden because you don't want people to know your business, or, different factors certainly play a role culturally and the way you're raised, so much to do with it. But I want to get it to a point where, like, yeah, I don't feel so great today, but I haven't felt great a lot of days. And to be able to go and talk to somebody where it's a safe environment, and you feel just more at ease or more natural about doing that as just you would, like I said, strep throat. So like our clinics, when you come in here, our waiting room doesn't look like a waiting room. It looks like a living room. I've got a fireplace that the inserts of the TV looks like a fire, but it's really chill and comfy. It almost feels more like you're going in Starbucks or something rather than, into a doctor's office, if you will. And from that point forward, patients are treated differently. We're very conversational with our patients to whatever degree they're ready to be. But because our treatments are these recurrent, people come in multiple times, sometimes for some of these treatments. What's fun is that I think there's this aspect that's hard to measure, that the social interaction helps people process the things they're dealing with, but become better. And I think that's some of the difference, to answer your original question of how do we get past this, is you got to talk about it. You got to get used to talking about yourself. I'm not that way. I don't like anybody staring at me. I don't like the attention, and especially if you perceive it as negative attention, right? If I perceive it as, oh gosh, I got to talk about my feelings and maybe past trauma, it's embarrassing in a way because we're not seasoned at doing that. So part of the answer to that question is a big cultural response. And that's huge. That's a big undertaking. We're not there yet.
Finding the perfect gift for everyone on your list, well, it can be quite a challenge. And when you're a busy professional trying to choose thoughtful, high quality, personalized gifts, you know that all too well. Thankfully, there's KML Expressions, a PA mom-owned business that can personalize almost anything. From ornaments to occupation-specific items for PAs and more, Crystal has got you covered. Don't even get me started on how cute her stuff is. Even the hardest people to buy for, there's a gift for them at KML. Head to the link in the show notes to place your order today. It's interesting because you would not see a patient in your office with strep throat or GERD or osteoporosis and think, oh, this is Michael's fault. He's just not doing enough to cure himself of this osteoporosis or this GERD. Like, you wouldn't think that. We don't put the responsibility on the patient to heal themselves for medical conditions, but which is interesting because those things do have lifestyle modifications that we could do to make them better and compliance issues. But for some reason, if it's medical, we think it's our job. And if it's mental, we feel like you should develop on your own skills and strategies as a patient to heal your own depression, which when you're depressed is even harder than when you're not depressed. So it's hard to cultivate strategies for mental and physical wellness when you don't feel depressed or anxious, when you aren't struggling with a mood disorder. So how can we as clinicians be less judgmental, probably of ourselves, but also of our patients when they're struggling with this? How can we help them more, even if we don't have a clinic in our town that is doing IV ketamine?
I think the first, probably most important step to that is studying yourself. It's introspection, it's self-analysis, it's self-awareness. There's not one of us that hasn't at some time had stress, experienced a low mood, experienced sadness, grief, whatever it may be, trauma. But I think, and it's more than just a casual of just thinking about it, like a remembrance of, oh, I went through this, or I had a period of time where I felt this way. It's truly like analysis, and it's sitting back and kind of thinking about, how did I feel? What did I experience? How did I feel? What was my response? Why did I respond? And we don't always, because we're busy, we don't always take the time to stop and think about the whys of who we are ourselves and why do we practice a certain way as a clinician. So I think to overcome some of that judgment is, one, if you've experienced that, acknowledge it, recognize it, slow down and pause on it for a moment, and actually do some thinking about it, because it's easier to kind of get through the day, because again, I've got to get the kids ready, I've got to pay bills, I've got to make it somewhere in time, I'm going to brush it under the rug. And the problem is with this, and that's what happens so much in mood disorders, is it sits back here on the back burner of your mind all the time until something triggers you, something sets you off, and then it's right here in the forefront of your consciousness, and your frontal lobe now tells you all about it, except that you're still busy. So you kind of muddle through it, or you get into a tiff with your spouse or your kids or something, and you never work past that same spot that's the same roadblock that you're always hitting, and it's there. So I think as providers, as humans, we have to study ourselves first. And then out of that, hopefully, is born greater compassion. And so your mindset and your approach to patients who are facing this becomes much different. And I think those clinicians out there that have done that or have experienced depression, anxiety, and of course there's myriad more things that you can face. Once they go through some of those events, tend to become softer in their approach towards patients and understand. And I think being able to come alongside patients is one way. And the second is, in that same vein, opening yourself up to that vulnerability, still in a professional patient provider relationship, but different than sort of the old school way of approaching patients is, you know what I went through was kind of unattractive, I'll say. It was messy, but I can come alongside and say, you know what, I felt that way. And depression is really exhausting. And I know how it feels. And I know how it feels to say, hey, you want to try one more medicine? And you're like, gosh, really? One more? I don't even know if I have it in me to say yeah. And those sort of things lead to some of the non-compliance and remembering to take your pill every day. Plus, you are depressed. Sometimes people can't manage those affairs. It gets that bad. So I think that self-analysis, that introspection is a big start. And it's not something that we're all trained to do or experienced or very practiced at doing.
Yeah, it's interesting that you say that. I think oftentimes on this show, I teach what I need to learn. And a whole lot of times my guests say something that I'm like, oh no, I knew he was going to say that we, like I knew I do not do well with slowing down. Like I am the person who listens to things on 2x speed, right? Like I'm just like, oh, why would you listen to it on 1x if you could listen to it on 2x? just, just that is just who I am. I just think it's great. I'm like, it's just more efficient. If I can do it faster, why would I do it slower? So I'm actually working with a coach on health and eating habits. And the other day she said to me, I call it the emotion tool because I don't know what its formal name is, but she says, hey, when you're feeling a certain way, I want you to pause. So immediately I dislike this exercise, right? I do not want to pause. I want you to pause. I want you to think about the feeling that you're having. I'm sorry, what? Okay, I'm going to pause. I'm going to think about the feeling that I'm having. I'm sorry. Like, and then I'm fine. Like I've lived my life, 30 plus years without this tool. And then she says, I want you to see where you feel that emotion in your body. And I am immediately uncomfortable thinking about this level of slowing down and tuning in to myself because I don't want to. I don't want to. I don't want to feel the feeling. I don't want to name the feeling. I don't want to feel where the feeling is in my body. But then the last part is letting that feeling go. So I do want that. And so in order to get that, I have to go through this pause, this self reflection. And as I was doing this, I thought, how could I have made it this far in my life without ever doing this? And I find myself doing it with not just eating, with dealing with my kids, with when I'm stuck in traffic, with when my husband pisses me off, right? All of these different things. I'm like, this is a tool. Why did I not know this as an educated, fully functional human being prior to this moment? It's so helpful. Also, I find it annoying because I don't like to slow down.
We'll get along just fine. It's all right. Same way. But you bring up a couple interesting points in what you just said, talking about slowing down and how instantly when your therapist that you're talking to or counselor was kind of instructing you to do this, the initial was like this like there's this tension, there's this little bit of dissonance in just your wiring, we'll say. Um, but that plays into so much like in neurobiology of what we deal with any of our patients, any of ourselves, because there's areas of the brain that, when you're under long-term stress, don't communicate well. And a good way to think about this, just kind of that initial cringy feeling that you get in being instructed to slow down, that just counter to what your day in and day out is like. When a good example would be like when I'm dealing with depression or under a lot of stress, I pull out of my office here and somebody cuts me off. There's part of my brain that says, no big deal. And there's part of my brain that says, well, screw you. Here's a gesture, out the window or something like that. And you could have one or the other ends of the spectrum response, right? But there should be a communication through parts of your brain that say, it's okay to feel that way. It's not okay to do that, and kind of this little, there's excitatory and inhibitory factors all the time going on in the brain. And when people are under long-term stress, and that could be depression or anxiety, or it could just be job, or it could be poor sleep, or it can be verbal abuse or mistreatment, so many things. there's parts of the brain that just stop talking to each other. They do a little bit, but physically or anatomically, there's mechanical changes in the brain, which I find fascinating, right? So neurons literally kind of migrate away from each other a little bit. And that's why I toss an SSRI at you, or an SNRI, or something that takes these monoamines and just floods that gap, hoping maybe I can make that communication better. So it's interesting to me that there's literally a physical change in your brain. And so I tell patients that, going back to one of your earlier questions about how do we normalize this, helping patients understand, like, this is a legit problem. I don't know if I want to call it disease state or how you want to refer to it exactly, but there's something here that's not within your control to make better. But that's what's cool about the treatments that we do with ketamine or S-ketamine or TMS, is we can make physical changes in your brain that then manifest as improved function. If you and I were to get into a tiff over something right now, every one of us has done it. We have some massive somatic things that happen, right? You mentioned it talking to your therapist. You had this like tension. So if you and I got into an argument, I'm going to feel like I don't have any spit, my tongue's sticking to the roof of my mouth. And so then I'm thinking, gosh, I sound terrible because I can't communicate as well. And then they can tell that I'm nervous because my tongue's sticky and I have no spit. And then that makes me feel flushed in the face. And then my heart rate's up. And then I feel a little bit shaky too. There's this massive cascade of events that happen physiologically. And that we've all experienced. That makes sense to us. We get that because we've all felt that. But on the flip side, like, for some reason, when we're under long-term stress, whether it's fight or flight or just the burden of insomnia that comes with depression or, low self-worth, for some reason, we as human beings in our culture think that should not manifest with any sort of physical complaints. And it does. It does massively. And so, as providers, I don't think we understand that completely. Because I don't know that we always know what we're looking at. But I think understanding that, and two, we were talking earlier about just kind of the mainstays of therapies. I mean, what do we do as providers? I have kind of a couple very limited options if I'm, say, in primary care or even in my office here. I can write you a medication. I can adjust the dose of that medication, the frequency of it. I can refer you to somebody else to deal with it because they have more time, so they can sit and talk to you. But even those therapies, like cognitive behavioral therapies and others, I mean, what are they doing? They're also limited in as far as they can go. And is it in perpetuity? Is it, short term? But I've already punted my responsibility or my capabilities to like a very limited, kind of finite point. And I think that's what, part of why we do what we do here at Stillwater is because there's different things that I can do that go back to what I was saying earlier, like anatomically make changes in your brain. And those manifest with different behaviors and different ways of thinking. They don't change you, but they heal you. And that's kind of what's fun about what we do.
You might not know this about me, but one of my most despised tasks as a clinician is charting. That's why I'm always searching for hacks, tools, and tactics to make charting more accurate, efficient, and less of a huge pain in the butt. If you too want to spend more time connecting with your patients and less time pointing, clicking, and typing into their chart, you should definitely check out Freed AI. Freed AI is a medical scribe on a mission to free clinicians everywhere from the purgatory that is writing notes. Freed AI listens, transcribes, and writes your medical documentation for you. You can even use the code PA50 for $50 off your first month with Freed AI. These notes are written in your style and done for you by the end of the visit. Can you imagine what it would feel like to leave work on time, notes done, without having to crack your laptop open in the evening? Freed is HIPAA compliant, completely secure, and it takes less than 30 seconds to learn. Get back to what you love doing, treating your patients, and let Freed AI do the rest. It's so incredible. And what a rewarding thing to be able to do where patients come in having struggled with something, having felt frustrated by one, two, three, or four medications that haven't worked, that have had lots of side effects. So I want to talk about building a practice in just a minute. But before we do, I would love for you to tell us, do these patients get better in a day, a week, a month? Do they get off of their medications? Do they need these treatments in perpetuity? What does that look like when someone comes to see you?
Yeah, good question. I can give you answers that's the whole gambit of that, but let's start from the medical statistics, boring literature standpoint. We can go through a stack of things, but let me give you some generic numbers just to for your listeners to easily digest to be able to see the contrast between this. So if you look at, we'll go to the STAR-D trial. STAR-D was done several years ago, one of the largest studies today that compared antidepressants. You could cycle through multiple antidepressants. It was open label, so it was trying to mimic real world practice of medicine and how providers prescribe. But patients didn't have to stay on the same antidepressant all through. So they would start with like citalopram, and they could go through others. But what they looked at is as they went from your first trial to your second trial of an antidepressant to your third and on, that the efficacy, the likelihood of reaching a response and or remission continued to drop with each subsequent trial. The discontinuation rate of those continued to go up. So by the time you got to your fourth antidepressant, you're under 7% likely to get the response you want from that medication. And that's the feeling that I felt sitting in my office, sitting across from patients. And you mentioned like 1, 2, 3, 4. We've got patients that have been on 20, right? So I sat there and I looked and I was like, gosh, 6.9% chance of getting better with that fourth antidepressant. And, going back to the strep throat analogy, like if I had an antibiotic that was likely to be that, let's say 30% effective, the FDA would never approve it, right? I wouldn't prescribe it to my patient, but we do it every day to the most widely prescribed group of pills. Okay. Take that example, and that's real world data across, I don't know, over 4,000 patients in over 40 centers. And with one dose of IV ketamine, you have the potential to have a 50 to 70% response with one dose. There's a great study out of France. They looked at 6 different psych hospitals with people who were acutely suicidal, and it was only looking at one singular dose of IV ketamine and the responses. And it was different than some others because they didn't weed out some other psych disorders. They look at kind of all comers that were suicidal. And they were having response rates in the 80s, 80%, 85% range within sometimes 40 minutes of one dose of IV ketamine. So meaning suicidal thoughts just went away. They couldn't have them. They didn't feel them. So that's looking at acute suicidality. The Spravato has great efficacy. That's the nasal S-ketamine. That's the prescriptive form of ketamine that's on the market. And then TMS has up to an 83% response rate and a 62% remission rate with no meds. We're just changing your brain electrically. And that's specifically in an area called the dorsolateral prefrontal cortex, which is kind of your pro-social behavior part of the brain. So we can look at all that just from like a statistical standpoint of, patients getting better. In the real world, just clinically encountering patients in here, what we get to see is, patients come in kind of sullen, not dressed in bright clothes, sunglasses on, hat pulled down, shoulders kind of slumped in. And then sometimes within just a few visits, or sometimes even with one, they'll come out and be like, gosh, things look brighter to me. They start smiling. They'll start joking around. They start cutting a little joke with you where they were kind of withdrawn at first. And you see this great evolution. And then the other cool thing is, I have some people that come in and their significant other then comes in because they see a difference in them. And we've had couples come in that I had a couple a while back that had been married 30 plus years, were on the brink of divorce. The one spouse came in, got treated, said, can you treat my spouse? And we treated them. And now they're both not only feeling better with their depression, but their marriage is revived because of that. And we see that time and time again. So some patients come in for a series of treatments. We try to cater it to the individual, but patients get stable, and then they also can come in for boosters, whether that's IV ketamine or we change the frequency of Spravato, or they can retreat with TMS. You can retreat all these. But to answer your original question, there's so much dynamic that influences that. We may help them feel better and get on a more level playing field, but maybe things are still tough at home, or things are still tough with their kids or job or whatever. So you still have to consider that. But the statistics are we can do it much more effectively than any other prescriptive medication on the market.
That is such a profound difference in efficacy. It makes me want to yell, like, why are we not doing this on every street corner? Like, why are we limiting access? Why are these clinics not more referred to and more well known? So, to the clinician listening who is wanting to send their patients to someone who can have this impact on that depressed patient who has been on, 4, 5, 7, antidepressants, where is there a good resource where they can find a clinic that is doing these interventions near them for their patients?
Yes and no. Mostly no. As far as like sort of a central hub to find that, there's not. And part of that is, the politics or the money side of medicine. On the TMS side, there's a machine sitting behind me that is one of the machines we use, but we use a couple different brands. So there's competition there. So you can always do your internet search and find and look for local providers that provide TMS or Spravato or ketamine. Spravato, being the only prescriptive form of ketamine, has a healthcare provider search engine on their website. So you can go to spravato.com, you can find it and search for a local provider that offers it near you. Clinics that provide that have to be RIM certified. It's a special certification program. It's very regulated, very safe, but it's you have to jump through quite a few hoops to become a center that can administer that. So they're not everywhere, but it's not complicated. So even primary care providers, if they're comfortable, can apply and become RIM certified and dispense it. But you have to be RIM certified to write the prescription and then also to dispense it to patients in the office setting. It's not something the patient ever handles themselves. It comes through a specialty pharmacy, so it's highly regulated. And then same thing for TMS, because there's so many different brands. You can go to the individual companies and find local, but you can really just do simple search engine and find local TMS provider or TMS near me or ketamine near me and start that way. And then there's it's called ASKP3, but it's an international society of ketamine providers as well, and you can search on that as well.
Awesome. Super helpful.
Trying not to give too many like specific plugs to different companies, but you can find.
No, I appreciate that. So the next thing I would like to take just a few minutes as we wrap up here to talk about is the fact that you went, and I love this beautiful description where you said, I was an employed provider, then I worked for a private practice, then I started my own practice. There are so many listeners who are maybe not ready to take that leap, but definitely interested in figuring out how to do that. What does that look like? Could I even do it in my state? Do I need to employ a supervising physician if I am a PA in a state that doesn't have full practice authority? So what resources, what have you learned along the way in terms of starting your own actual practice where people come in and see you?
Maybe we should have started with that before we wrapped up, right? Because I'm sure there's an endless laundry list, and there's always some other surprise around the corner that you're like, I wish I had known that a year ago, or something like that. So, where to begin on that? So part of my approach was, one, I studied everywhere I've ever worked. I've always tried to look at the economics of where I was. So as PAs, we're all doing that, right? Some of us are on RVU models and bonus models. So I started to really analyze that and look at and track for myself, like, what kind of work am I doing? What kind of income am I generating for this practice? What do the reimbursement rates look like? And so I studied all the different carriers and I studied and looked. So I was educated for myself in my employed positions to be able to negotiate on my behalf. Because to be honest with you, like when I started practicing, I was kind of sheepish. It's like I don't I don't know how to say this without sounding arrogant. Like I knew I did good work, right? And I had a manager once that told me, you know, people who do good work know they do good work. And I think as PAs, we know how hard we're working, we know what we're doing, but that doesn't always totally equate to a monetary equity to that. As we know, looking at an RVU, a really worthless structure that we have in America of how we determine a value for what you do, right? So you also have to be strategic because it's a business too. So you have to sit there and think, well, gosh, yeah, I could spend 40 minutes with Mary so and so and do this, or I could spend 2 minutes with Joe and do a simple procedure, and I made way more money for this practice, and that's what they care about. So that's where I started. I started looking at like, why are they not giving me this huge bonus? Because man, I've been working my tail off. And so you've got to start with kind of this analysis that lets you be educated. Then I started reading. I just started reading a lot, and there's a lot of books out there, both for PAs and physicians and nurse practitioners. I started looking at just business um, texts, but there's a lot of books you can find out there with mostly physicians who have gone out on their own. So I tried to learn from them and those that were maybe getting burnout on medicine and why did they do that? And then what did they learn? And so that let me at least kind of have my antennas up to watch. Then years ago, I made a move to another state and decided to partner with this other physician who had started a practice and worked with him for a few months. And then he got this super attractive offer to go do something else and get paid a lot to not do very much. And it's like, hey, I'm going to close this business. And I thought, like that moment where you're like, well, that's really inconvenient for me. And so in a hurry, I decided to buy that practice and was able to do that with relatively low threshold, but not having a clue, honestly, what I was doing, and had to learn kind of flying by the seat of your pants very quickly to know from what's malpractice cost me, what do I have to pay a coder and biller to keep the funds coming in, how do I file an insurance claim, so it forced me to do some immediate research. So for those of you listeners out there that are interested, um, one, you can email me anytime and we can talk about that, or you can call my office. I'm happy to share that knowledge. But there's a lot that needs to be done just from a research standpoint. So you have half a clue going into it, and then the rest of it is very much individualized into the practice that you're creating, the community you're in, but learning everything from business insurance and business licenses that are local that would be different in every area, to accounting, to how to keep good records of things and how to be a manager, how to be a leader, how to be an employer, how to learn labor law. There's a lot of challenges for sure. So, how to begin? Um, read, read a lot. That's one of the best. And talk to other people like people who have started their own business who can tell you, not talk you out of it, but it's not always easy, but it's also a lot of fun.
Sure. I have a lot of fun. It is so worth it, but I had no idea what I didn't know. I think it was just like when I first started practicing medicine, I thought I knew what I was doing and I did a little bit, but I didn't a lot, and I had to figure those things out along the way. This will be the last question that I ask you before we wrap up, but how did you have the confidence to think that you could do this? There are a lot of people listening who are thinking, I would love to make all the money in my practice. I would love to have, this thing where I made the rules and I got to make the culture and I got to make sure that my patients were getting really great care. But am I qualified to do that? What made you think that you could pull this off?
Hmm. I think a couple things. I'll give my wife a lot of credit just to be an encourager. It's nice to have somebody who is in your corner, that, because I'm sure like there's days that I'm like, man, this is awesome, this is going great, and the next day you're like, yeah, forget it. I'm walking out in the woods and disappearing, and what did I ever do this for? So there's those days that you vacillate back and forth. But to have somebody who is a cheerleader for you, I guess, in some degree, um, has been a blessing for me. But at the same time, too, I think going through difficult things also helps you have that knowledge that you have the resilience to do so. And that can be hard things in an employed position, because I've gone through those, where you feel like you're not maybe treated as well or as fairly as you ought to be. There sometimes has to be this impetus that's kind of that spark that lights that fire under you that says, enough is enough. You shouldn't be treated that way. You should be, respected more for what you're doing. So sometimes that's an impetus. And I think to give you the confidence too, um, confidence can be confused with ignorance too. I think in this, not like you said, not knowing what you don't know. So that helps, right? But I also think, having gone through like difficult things too, you can, going back to what I said earlier, just that own introspection and self-analysis, not to drag the answer out too much, but to tell you a little bit, just personal story as to why I did it, did this clinic and did this business. I have other businesses that support this business and are intertwined into it. And it's become easier with each subsequent one to open those businesses and know how to better structure them and how to start them off on the right footing. But years ago, I went through some terrible things personally and got to where I was pretty low in life. And so I went and sought out some of the treatments that we provide, and I realized the success in it and how that helps people. And going back to kind of what I was talking about early in our conversation is in helping providers have that compassion, for people. This may sound really corny. I don't even know how it's going to come out, but I love people. Like I genuinely, truly, like really deeply care about people. So part of the drive on my business is I want to help other people succeed. So the whole structure of my business from the get-go was trying to build it in a way that other PAs can go into business on their own and maybe lower the threshold for them to get there. So we have a model as we open future franchises. Each provider has the ownership in the has a piece of the pie in that, and we help them get started, lower the threshold, but then it becomes theirs more over time in that franchise. So that's one. Two is each of my individual employees, I love them. I care about them very deeply. So I help them pursue more education, or I give them more training and more skills. And if they prove themselves, they get more responsibility and they get a piece of the pie as well. And at the end of the day, it profits me. It helps me. Not that that's my motivation, but I think having sort of a selfless mindset is what you have to have too. You can't go into business thinking, I'm just making these big bucks and that's enough, because it won't be, and it won't sustain you. And the money won't sustain you either. And sometimes the money's not that great either, depending on what you do. Or there's times where you're like, gosh, that, cost me a whole bunch. And you can't think of it that way. You got to see the big picture. And then even in the structure of what we do with our businesses, we have, I don't know how you want to term it, charity or sort of free services built into the financial model of this, so that 10% of all of our profits immediately get taken off every month. Like that just disappears. We pretend like it's not there, and that's given to people who can't afford, but that also need what we offer. And so that's kind of fun too, to just pretend like you don't have that and to see that. So it all boils down though to like loving people and caring people. That's the motivation behind it.
Yeah. I think the most interesting part about that story is when you and I were chatting before we hit record, we talked a little bit about how it feels to be an employee working for a company where you don't benefit and they don't love you and they don't care about you. So the fact that what you have built is at the exact opposite end of the spectrum, where people working there do have the opportunity for growth and they do have the opportunity to have a piece of this wonderful thing that they're giving, that they're building, and that they also get to profit. When we do more, when we work more, we make more. It's such a better place to be in as a team member. So not everyone listening to this is going to go open their practice, but maybe this will inspire them to find a practice that values them the way that you value your team members. That is so, so important.
We should be. We're all pretty important people. We're worth it.
Well, Mikal, thank you so much for coming on the show. This has been such a wonderful conversation.
Yeah, thanks so much for your time. It's fun.
I love any conversation where we talk about the need to feel loved and appreciated and like we are making a difference at work. I hope that this episode reminded you that it's normal to struggle and it's normal to have challenges with your mental health. And when we pause and reflect on our own experiences, judgments, feelings, and abilities, that can open a door to have better, deeper, more connective conversations with our patients, and also lent you some great resources that you can use in your clinical practice starting as soon as this week. Thank you, as always, for tuning in to another episode of The PA is In. That's all for today. This PA is out. Congratulations, you've just joined an awesome club. By listening to a full episode of The PA is In, you are officially on the Unicorn PA team. Welcome aboard. What most team members do is they subscribe to the podcast because that allows them to automatically get the latest episode of the show. The life of your dreams exists on the other side of taking action. Keep making small shifts and keep getting better. Your life will improve, your career will soar, and you will have the confidence you need to create your own success. I will see you in the next episode. This PA is out.